Shall we start, I think? Yeah. Okay, well, we'll make a start. Welcome, everybody. Thanks for tuning in for this, our latest webinar from the Health Services Research Association of Australia and New Zealand. So you can see our nice logo that we've developed for our next conference, which is a little bit of a way off, but never too early to get the date in your diary. So we've been holding these webinars since late last year, and this one's a little bit different because I ought to introduce myself. I'm John Karnon, president of the association, but I'm actually going to also be presenting as part of the team presenting on this webinar. And so the topic of today is around obesity management in primary care, and this whole topic comes out of the Centre for Obesity Management and Prevention Research Excellence in Primary Healthcare, or Compare for short, which we three speakers are all part of. And we're going to be talking today about options for managing obesity in primary care, in general practice in particular. We've got three short presentations. The first presentation is going to talk about the current context, the current service options and barriers and facilitators to managing obesity in primary care. The second presentation is going to describe some evidence that we've collected around a new service option, particularly involving practice nurses in the management of obesity. And thirdly, an even shorter presentation is just going to be putting forward essentially a research proposal that we think would be useful to generate the evidence to support and inform the uptake and funding of new service options in this space. So the housekeeping, I guess, main one is around questions. So as you're aware, we can't hear you, and so we're going to use the chat function. So if you have any questions that arise whilst we're speaking or after we're speaking, please just send them through via the chat message, and I'll relay them to the relevant speaker or to the group for further discussion. And so you can do that at any time, and I'll just relay the questions at an appropriate point. That's pretty much it. So I'll move on to introduce our first speaker, which is Mark Harris, who's Professor and Executive Director of the Centre for Primary Healthcare and Equity at the University of New South Wales. He's also the Director of the Centre for Obesity Management, the Compare. He's led many studies in primary care with a focus on chronic disease, obesity, and particular interest in health literacy. So today he's going to talk about the study of referral options for obesity patients managed in general practice.
Thanks, John. And I'll be giving an indication to, if you could just go back a slide, Jodi, to Jodi, who's controlling the slides. I'd like to start off by acknowledging the traditional owners of the land we're all on and pay our respects to the elders past and present. As John has already said, the Centre for Obesity Management and Prevention and Research Excellence in Primary Healthcare, which is Compare-PHC for short, involves universities and collaborating organisations across 3 states, together with some international partners as well. So you can see them at the bottom of the screen. Some of the Australian universities, UNSW, University of Technology, University of Adelaide, Deakin, Sydney, also the Inala Health Service in Brisbane, and the universities of Otago in New Zealand, Robert Gordon in University in Scotland, and CDC in Atlanta. so we've had investigators involved in the centre for the past 4 years, and it's just coming up to the 4-year mark where we'll be, which will be something of a transition for the centre. So if I could have the next slide. Thanks, Jodi. So what I'm going to cover in this first section is to talk about some really background information about, particularly focusing on referral in primary healthcare. And I'll be talking about the 5 A's and how it relates to some of the guidelines that are in use for the management of overweight and obesity. The study which we conducted in New South Wales, in 4 areas of New South Wales, rural and urban, looking at specifically at the referral pathway from general practice for patients who are obese, and some of the options and features of that are available, particularly for behavioural or lifestyle interventions. This is this work is based on the National Health and Medical Research Council Clinical Practice Guidelines for the Management of Overweight and Obesity in Adults, Adolescents and Children, which were produced in 2014. And those guidelines are actually structured around the 5 A's, which I'll be talking about in a few moments. So Jodi, if I could have the next slide, thanks. So this really is just about some of the importance of obesity in primary healthcare. Patients who have a BMI of over 30, which is their current WHO definition of obesity, are frequently seen in primary healthcare. So in the BEACH study, for example, in 2002 to 3, about 21% of patients who attended primary healthcare were found to have a BMI of 30 or more, and that had risen by 2012-13 to 26%. So about a 5% increase over that decade. And that's been consistent with shifts in the general population, with increased number of people in the overweight range and an increased number of people in the obese range. As I mentioned, the National Health and Medical Research Council guidelines for the management of overweight and obesity recommend a multidisciplinary approach to managing that condition across the 5 A's. And so that they are ask, assess, advise and agree, assist and arrange, which is 6 A's, of course, but these are variable how they're put together. Ask is really about just identifying people in whom you consider an intervention, whereas the others relate to what should happen during an intervention, and that's what we'll be focusing on. So if I could have the next slide. So the 5 A's to preventive care are really just a framework for thinking about how we should be managing overweight and obese patients in primary healthcare services. And that starts with assessing people's risk. So apart from measuring their weight and height to calculate their body mass index, but also waist circumference. But assessing and whether there's any other medical conditions or treatment that might influence our management, and whether there's any consequences of overweight and obesity, such as early diabetes or high blood pressure or heart disease and so on. But in addition to all of that, assessing people's motivation to try and change their weight, and their level of health literacy or their knowledge and understanding. And in Compare, the centre, we've been doing quite a lot of work about health literacy, and there'll be a seminar in a few weeks' time where we bring some of that work together as well. The second A is about providing advice. Advice about what that risk means for patients and why it's important, but also advice about some of the consequences of being overweight or obese in that particular patient. And very importantly, agreeing on some goals, common goals, and perhaps some targets for what might be achieved in terms of changing lifestyle behaviours like weight and physical activity, but also goals for weight. And generally speaking, those goals, particularly for lifestyle or behavioural interventions, are in the range of a weight loss of 5 to 10%. The next A is about assisting people, and that can be assistance that's provided within general practice, within other primary healthcare services themselves. But generally speaking, most practices in Australia have quite limited time available for interventions, particularly GPs themselves. And so while they can provide some support and advice, it's quite difficult to provide the sort of level of education and support and behavioural interventions that are required to help people to lose and to maintain weight loss. So to lose weight and to maintain that weight over a period of time. And so we're talking at least a year, and preferably much longer than that we'd be aiming to assist patients to achieve a 5 to 10% weight reduction. And so that usually means involving some more intensive interventions, usually 6 to 8 sessions of advice, information, support, perhaps some behavioural interventions as well. And that's usually something which is beyond what's normally provided by a GP in their clinical practice. And the last A is about arranging follow-up. So the sort of long-term support that's required, and that is particularly in terms of maintaining not only changes to diet but changes to physical activity. It's relatively easier, I won't say it's easy, but it's easier to modify your diet and to do more physical activity for a short period of a few months. It's quite difficult to maintain that long term. And many patients, in fact the majority of patients who are obese, have already tried to lose weight, and some of them have lost weight but then regained it subsequently. So this is the framework within which weight reduction, particularly using lifestyle interventions, behavioural interventions, is what's used in primary care. So if I could have the next slide. So this is from another study that we're doing in Compare called the Better Management of Weight in General Practice, and this is the baseline information. So this is before patients had any intervention. And this is looking at patients who are obese, so patients who've got a BMI of 30 or more in general practice. And we asked patients in the previous 3 months, have you had any of these from your GP or practice nurse? And so you can see the majority of these patients had their waist measured, and in fact, the majority had their waist circumference measured. Although the levels of measuring waist circumference are quite low still in general practice, at least in this group of patients who are already identified as being obese, they're getting that done quite often. However, so those assessment activities are happening, and they're fairly appropriate. The next bar, though, is lifestyle advice. So this is patients recalling that their GP or practice nurse gave them some brief advice about their diet or physical activity. And as you can see, only 40% of these patients who are obese could recall any advice from their GP or practice nurse. And the proportion that were referred were lower still, so less than a third. And of those who were referred, only about half actually attended when they were referred. So some very significant issues with not just doing an assessment, but actually providing even brief advice or referring for some more intensive support to help patients to lose weight. And so that was the sort of basis of this sort of finding, and we've found this in other studies, so it's not just in this particular study, including some large population cohort studies. We found a very similar pattern. Was to really understand why why GPs were not referring more patients in that, particularly patients in the obese range, that we undertook the study. So if I could have the next slide. So we interviewed GPs. We interviewed 10 GPs in 4 primary care organisations across New South Wales, and they were urban and rural and semi-urban areas. And we asked them about what were the factors that influenced their referral. And in this study, we're actually looking at referral both for behavioural interventions and also for surgery. And so we asked them to think about patients who are obese, particularly patients who had a BMI of 35 or more. So this is category 2 obesity. So no question that they had a problem. This was not people who were just a little bit overweight. They were thinking about people who were quite obese. And in these in-depth interviews, we explored some of the factors that influenced them. And the first factor, and so what I'll present is just some of the findings about the referral for behavioural interventions for lifestyle type interventions or programs or providers like a dietitian or an exercise physiologist or a group program for weight management, etc. So these are some of the factors that we found were important in referral decisions about whether to refer patients to those services. And the most important was the issue about perceived effectiveness. And quite a lot of the GPs were very sceptical about whether these programs actually worked for their patients. This was often based on very anecdotal evidence, so that it was not based on, findings from an evaluation study of the particular service or provider, but more the kind of anecdotal feedback, particularly when patients came back to them. And unfortunately, what tended to stick in their minds was some of the negative feedback from some patients. So there's a quote there from a rural GP. Most of them go and say, "I really didn't learn anything I didn't already know, or that you hadn't told me already, doctor." And another GP in an urban area saying, "On the whole, I'd say the success rate is quite low in terms of major changes." And again, there's a question about what was the expectation, whether there was an expectation of much more significant weight loss. So we really do need to manage patients' expectations, and certainly a 10% change in weight, so it may be only somewhere between 8 and 10 kilos that people might lose, is still a very significant and important change that can have major health benefits. So I think the important thing about that was that many GPs are unconvinced about whether you're talking about referral to an individual provider like a dietitian or a program, a group program, or in fact some of the online services, and I'll talk about those in a moment. And that was often based on anecdotal feedback by the patient, because most GPs reported they didn't get anything back. They didn't get a report back when they referred people. The second thing was patient motivation. And there's some quotes there from some GPs about concern about motivation. And on probing, we found that often GPs tended to conflate motivation with health literacy. So patients, and we found this in other studies, patients who've got poor knowledge and understanding, the way they behave is by not asking questions, not engaging. They appear to be not motivated when the major problem is they just don't understand. But nevertheless, motivation in the minds of the GPs is a major issue. The next slide. The third area of barriers was system factors. And here, the major problem in these 4 regions of New South Wales wasn't so much not having anything available, but the problem was the access problem that was most important to these GPs was about it being appropriate. For example, being in the right language for their patients, or having a program, for example, a group program that was suitable for men, not just if the whole of the group, rest of the group was female, the men wouldn't necessarily attend. So finding a service that was appropriate for their patient. And this wasn't necessarily the same across the whole of that particular practice. So you might have patients with different languages or different gender or different cultural background or different interest in how they had the program delivered. So they needed a choice of programs to be able to offer people was the major issue of appropriate services. They needed to be evidence-based, of course, but they needed to be also appropriate for those patients. And again, this issue about communication back. So particularly in the public sector, many GPs reported that when they referred people, it was like referring into a black hole. And so that feedback was important, not only in terms of helping them to see whether it worked, but also as a way of reinforcing and continuing to offer it. So if I could have the next slide. So this slide just really summarizes what we found. And I've highlighted in red 2 of the most important factors for in GPs' minds in terms of influencing them to refer to a behavioural or lifestyle service or program. And all of these factors were raised though. So also the extent to which they felt empathy with the patients and their concern influenced them. The fact that the guidelines recommended it had a small influence. Patients' health literacy also. There are also some issues about work capacity, and this influenced the ability of the practice to do something themselves rather than refer people. And that included the capacity not only of the GPs, but the practice nurses, what other roles and tasks they had to perform. And transport was a major issue. If patients had to go to another provider or to a group program, transport and the appropriateness of services were important. So all these factors influenced whether GPs referred. If I could have the next slide. So, and the referral rates we found again from other studies, and as I showed in that previous slide, really varied, but even for patients who are overweight, the referral rates are less than 10%. For patients who are obese, they're a little higher than that, but still majority of patients are not getting referred. So this is my last slide. What I've attempted to do here is to just list some of the, in the first column, you can see the major referral options that are available in many areas of Australia. So referral at an individual basis to a dietitian, exercise physiologist and psychologist is the first of those. And that's reasonably acceptable and reasonably available in many areas, and does accommodate people's needs. A big problem there is language and cultural background. It often doesn't match the needs of the patient. The other major issue is affordability. So for patients who've got a chronic disease, there is the ability to do a care plan and refer patients for 5 occasions of service, and that's usually not enough, even if that was all going to a dietitian, for example. But often that has to be, if someone's got a chronic condition like diabetes, they need to see multiple allied health providers about foot care, for example, and so on. Group programs is another option, so referring them to group programs, and that's, again, reasonably available. These are available in a lot of areas, but the issue is there about how acceptable and accommodating that is to individual patient needs. Again, language and gender I've mentioned. Most of the group programs that are provided by state governments or primary health networks are highly subsidised, if not free. But there's some real issues around getting to them transport-wise and how they fit with patients. Telephone coaching is another option. The Get Healthy line that's available in New South Wales and South Australia, I think Tasmania as well. But there is other telephone coaching lines that are available in some of the other states. These are clearly affordable because they're generally provided at no cost, and in New South Wales and South Australia at least, the telephone coaching service will ring people back if they're referred to the service, so they don't have to have phone charges. And it's available in some other languages as well, but there is, again, that's not applicable to everyone. Not everyone finds it easy to use or wants to be rung on a weekly basis about their their diet and physical activity and weight changes. Practice nurses are because it's within the practice, are providing a program, and we'll hear some more about that. Generally the referral's easy and it's acceptable to patients. Sometimes the practice nurse doesn't speak the language of the patients that might need to be referred in that practice. And there is an issue about how that's funded and how affordable that is, particularly for patients who aren't on a care plan. And then there are private programs, and there are relatively few that have been. Weight Watchers is one that has been evaluated in properly designed research studies. Relatively few of the others have been, and they're relatively available and acceptable. The key issue there is affordability and cost, and that's something which in Australia, because those programs are not subsidised, that's a barrier. So that is really the end of my part of the presentation. So I'm happy to take any questions before we move on to Jodi.
Thanks, Mark. I think you were obviously exceptionally clear, because there's no questions relating to the content so far. So maybe we'll move on to Jodi, and then obviously we can have take questions after Jodi's talk that can also refer to Mark's talk as well. So how do we get to Jodi's? There we go. So I'll introduce Jodi. Jodi's an experienced health services researcher. She's been working in the area of chronic disease management in primary care for the last 7 years with myself and others here at the University of Adelaide. She started working on an ARC project that looked at the role of practice nurses, and this led into the investigation of the counterweight program, which she's going to talk about today. So I'll pass on to Jodi.
Thank you. Oops. Okay, so part of the work that we did, and part of what came out of the original project that I was working on around practice nurse involvement in weight management, was to look for a way that we could get nurses more involved. So something we could offer them to increase their engagement. what we identified was the counterweight program. So this was a structured weight management program that's delivered by practice nurses. It was developed by researchers, clinicians, dietitians who are based at Robert Gordon University in the UK. So the program was based on the best available evidence about weight management support, behaviour change strategies, and it's consistent with the Australian guidelines, so the NHMRC clinical practice guidelines that Mark spoke about around management of overweight and obesity, particularly in adults in this case. The program's been used in the UK for 15 years. It's been rolled out in routine practice in practices across the UK and Scotland, so it's been shown to promote weight reduction and weight management in routine care. The aim of the program is to help patients achieve and maintain a weight loss of about 5 to 10% of their starting weight. So this is enough to give them real health benefits. It's enough to reduce the risk of cardiovascular disease, diabetes, and also to improve the management of chronic diseases that are already present, so things like diabetes. And it fits with the recommendations of the NHMRC guidelines around aiming for that 5 to 10%. So we position the program as an intermediate level intervention. It's based in general practice. It offers patients the option of structured weight management support. It still allows for more complex patients or patients who don't achieve success with the program to be referred on to allied health providers to consider weight management medications or bariatric surgery, so to seek out additional support. So nurses receive training to deliver the program. The training at the moment that we've used in Australia is online and highly interactive. It's very much an online classroom environment. They receive initially 12 hours of training, and that's broken down into 2 to 2.5 hour blocks. And this covers training in the program, content and around weight management, but also some mentoring with case studies and that sort of thing to build their skills. There's ongoing support that's available through phone or email, and this is all provided by an experienced counterweight dietitian who's based in the UK at this point. After the initial training, 6 months on, they also have a bit more training that helps consolidate their knowledge and also to discuss anything that they're seeing in their experience, so as they're rolling out the program to their patients. Once nurses have had that initial training, they're able to deliver the program to patients in their practice. So it starts with a screening appointment, and in that screening appointment, they check the patient's weight, their waist circumference, and discuss it with the patient, and then discuss the program with the patient. So here are your options around weight management. This is the kind of commitment that's required, and to help the patient decide whether now is an appropriate time, whether they're able to make that commitment, whether it's important to them to do something about their weight now. So patients who are ready and want to enrol in the program then receive 6 sessions that are spaced fortnightly over the next 3 months. And this is where the bulk of the information around healthy lifestyle, so healthy eating, physical activity, but also behaviour change strategies is delivered. Following these 3 months, the patients are then offered follow-up appointments at 6, 9 and 12 months, and these focus around weight maintenance and sustaining the behaviour change that's been made. Patients can receive optional check-in appointments where they have that 3-month gap between appointments, but the aim is that they become independent, they develop confidence in their own skills. It's not that they become reliant on the nurse. So the program is supported by some structured, well-developed set of materials that are available for the nurses to guide them, but also for the patients. So patients receive a folder. At the moment, it has inserts that get given at each session that they attend. So each session, they get a set of inserts that builds on their knowledge and consolidates it. So the idea is they're not hit with a lot of information or a big book up front, but they get fed the information in bits and pieces to build up their understanding. So in thinking about rolling out a program like Counterweight in Australia, we recognised from the beginning that there was a need to identify sustainable funding options, and that would then support sustainable program delivery. We recognised that we needed to find options for funding the practice nurse training and also the supply of patient materials. We also need to identify options around those counterweight session payments, so the delivery of those sessions to the patients. And this could be around using an existing MBS item number, so the GP management plan is a possibility, but this would restrict the eligible population. So at the moment, it would need a patient who can have a GP management plan really focused on weight management. So that wouldn't work for a patient with diabetes where they need the visits with the nurses that are done under the GP management plan. Those visits are needed to manage their diabetes and to educate around diabetes specifically. It may be that we need new MBS item numbers, so this would require gathering evidence around effectiveness and cost effectiveness and making an application to the Medical Services Advisory Committee, which makes advice around what items should be covered under the MBS. So as a first step to considering Karnon weight for use in the Australian context, we first needed to find out whether it was feasible to deliver it here and whether it would be acceptable to Australian general practices and patients. We also needed to find out whether there were any refinements that were needed to the materials to make sure that they fitted in the Australian context. So we have done a pilot or a feasibility study of the program. And also as part of that, we wanted to refine our study methods in preparation for this idea of doing a larger scale clinical trial, which would help gather that evidence around effectiveness and cost effectiveness. So the pilot study was done in 2014-2015. We recruited 3 general practices and we trained up 2 nurses in each practice to deliver counterweight. Across the 3 practices, there were 65 adult patients who were enrolled in the program in the pilot study. So because we had funding and timing constraints around this pilot study, we had to focus in on that screening appointment that I spoke about and also the sessions 1 to 6. Also because we had this idea around perhaps we need a new MBS item number to cover the session. We wanted to trial this idea of offering a subsidised payment or a payment for each of the sessions delivered. So we offered practices in the pilot study $25 for sessions 1 and 2, which was slightly longer, and then $20 for sessions 3 to 6, which were slightly shorter sessions. To evaluate, we've used data from patients' medical records, so the routinely recorded weight and height and waist circumference information that was collected as part of the program, but also information around their demographic characteristics and comorbidities and those kind of things. We also did semi-structured interviews with the practice nurses, the GPs, the practice managers, and the patients who are enrolled to find out what their experience of the program was. If we take a look at the baseline characteristics of the 65 patients that we enrolled, we can do a bit of a comparison of our 65 with those who have enrolled in previous evaluations. So there are 2 previous evaluations, both were observational and they did have a control group for comparison. So one was done across the UK and then the second evaluation was focused specifically in Scotland, where the program was rolled out under a government initiative that targeted patients who were in the most deprived regions of the country and who didn't regularly engage with general practice. We can see that our patients are fairly similar to the evaluations done in the UK. They're predominantly female. They have a mean age of 50 to 55 years. They have a mean baseline BMI of 37, and around half of them have 2 or more comorbidities. So they're quite a complex patient group. Oops. No, that's right. Okay, so if we look at the findings from our pilot study compared with the UK, and we need to bear in mind that our pilot study wasn't intended to evaluate intervention effectiveness. We're not reporting on statistical significance of the results. We only had 65 patients enrolled, and that's compared to the thousands that have been enrolled in the UK evaluations. It's possible that because we're a feasibility study, the nurses who were involved were perhaps more motivated. Some of the patients might have been as well. And we only have 3-month measures, where in the UK they have 12-month measures. So bearing all that in mind, what we found was 75% of our patients completed those initial 6 sessions. And this is compared with 55% in both the UK and Scotland. So for those who attended those sessions, which reached about the 3-month mark, what we find is that they had a mean weight loss of 4.6 kilos here, which is slightly higher than the previous evaluations. And we also find that more of our patients lost 5% or more of their baseline weight, so reached that target goal. So we had, 39% compared with the 19 and the 26% that were in the UK and Scotland. If we work that across all enrolled patients, we find that in our study 28% lost 5% or more, and that's compared with 14% and 10%. So bearing in mind for the 10% in Scotland, it was that more difficult to engage patient group. So we are seeing some good results in our pilot study, but they are preliminary. If we look at the interviews that we did, we found that the practice staff who were involved in the program saw it as valuable, and they definitely saw a need for it. They were very concerned about the levels of obesity that they were seeing in their practice. They valued having something in general practice that was beyond what it was possible for a GP to offer during a consultation. And this speaks to the idea that GPs really do have limited time and they can't offer anything, they couldn't offer anything as substantial as counterweight in the time that they had available. They also talked about the value of having something that was structured and seen as a program available within the practice. The practice managers, the GPs and the nurses all said that counterweight fitted into their practice with minimal disruption. So provided that the nurses and the reception staff were able to space the appointments across sessions rather than having a lot of counterweight appointments in one session, the workload on nurses was quite manageable and it didn't place any extra burden on the GPs to have the program in their practice. The nurses said that the online training was interactive, it was supportive, it was very well received generally, and the program materials, both for the nurses and the patients, were seen as easy to understand and great resources. Both the nurses and the GPs were keen to see the program keep being delivered in their practice. They wanted to continue with it after the pilot study, and the GPs spoke to the idea of they hoped that it became standard care, but they were very clear that they needed further evidence of effectiveness, and particularly over the long term. So at least 12 months, much longer or longer. In the interviews with patients, the patients described how the program created a safe space for them to learn about weight management, to explore the factors that were contributing to their weight and to make changes towards a healthier lifestyle. They talked about the qualities of the program being non-judgmental. They saw it as being non-prescriptive, so it wasn't seen as a diet as such, but that it was offering them information and helping them problem solve the barriers that they were facing. The program had fairly broad definitions of success, so although they were targeting this 5% weight loss, there was also a lot of recognition given to changing towards healthier lifestyles and that shift that was happening. There was also a sense of accountability that came through. They knew somebody was monitoring them, they knew they were checking in with someone was paying attention to their weight. Patients also commented on the value of having something in general practice. And so this created a sense of comfort for them, a sense of trust, and also accessibility and convenience. Patients who often had multiple comorbidities and medical appointments all over the place talked to the value of not having to go somewhere else, being able to go to the practice where they were familiar with the staff and it was convenient and close. So overall, the findings from the feasibility study suggest that practice nurses can deliver a structured weight management program. There is a role for practice nurses in preventative health across the 5 A's that Mark talked about, but that we do need further research around the program's efficacy and long-term outcomes, so looking at least 12 months within Australia. The program appears to be feasible and acceptable to Australian general practice staff and patients, but we still have this question around finding adequate and sustainable funding, and how do we find a funding structure that supports the program to continue to be delivered.
Great, thanks, Jodi. We've still got no questions, but I'll just remind you that you can post any questions or comments through either the chat function or the question and answer function, and we'll relay those questions to the speakers. So I'll push on to the final presentation, which is around a proposal that we've put together to evaluate or to extend our evaluation from a pilot study to a full evaluation of the clinical effectiveness and cost effectiveness of the counterweight program in an Australian context. And we've got a couple of options, so it'd be good to get any feedback on what you think would be the more appropriate research proposal, and in particular if there's any PHN representatives or other people out there who'd be interested in being involved. We'd be clearly interested in that too. So referring back to Jodi's earlier slide about options, so we're really thinking in terms of evaluating counterweight in the context of these 2 options. The first one being where we evaluate the provision of counterweight using existing MBS item numbers, in particular the GP management plan. The issue there being we'd have a restricted eligible population. Or secondly, alternatively, looking at introducing or evaluating new MBS item numbers that are specifically targeted at the funding of the counterweight program. So if we think about how the funding might work through the MBS, whether it's with the existing items or new items, the same general structure would apply, that we're involving the GP in the early stages of the program, and then moving into a phase where the practice nurse is primarily providing or presenting the information through the 6 intensive sessions. And then maybe the GP comes back into the picture for the review portion of the program over the first 12 months. And clearly there's some options around how that would be organized if we were using new MBS items, but this is just giving an example of how the program could be funded, and is actually being funded by some of our pilot practices. Now that we've stopped funding the practices are actually continuing to provide the program as best they can within the constraints of the funding options that are available. So what we're proposing is an NHMRC partnership project, what we're hoping to develop. And the way that you might think about a partnership program is that we're combining partner-funded provision with NHMRC-funded evaluation, which gives us this concept of evaluation in practice. So that's really the context behind the partnership. And so in terms of the evaluation options, we're really thinking about one of 2 head-to-head trials, either evaluating the provision of the counterweight program using existing MBS item numbers, or evaluating the program in the context of proxy MBS item numbers to inform an application to the Medical Services Advisory Committee. We've thought about the possibility of a 3-way or a 3-arm trial, but it really would get quite complicated to design such a trial. And so at this stage, we're focusing on one or the other of these options. Clearly, the process for translating or implementing the results of a study in which we're using existing MBS item numbers would be easier. The advantage of designing the new MBS items is that we'd have a much larger eligible population, which would meet, we believe, the needs of the population to a greater extent. So very quickly, just giving you an overview of the plan. We're obviously a collaboration between the University of Adelaide and the University of New South Wales. We're hoping to identify 3 partners in addition to Counterweight Limited. So Counterweight Limited in the UK have been involved with the pilot study and are keen to be involved going forward, and so they'd provide some contribution to the evaluation, and of course the NHMRC who would fund the evaluation component of the project. So in a nutshell, we're aiming to identify or to recruit 30 practices. So that would be 10 practices per partner, so per geographical area. And as part of the trial, in each geographical area, 5 practices will be randomized to the intervention, 5 to the control. And our sample size calculations are that we'd recruit 20 patients within each of those 30 practices, so 600 patients in total. We clearly need to consider the incentives for the control practices, and so we've built in a commitment for provision of training and funding around the 20 patients, so that the control patients can provide the counterweight program, receive training in the counterweight program at the end of the trial. And so in terms of patients who receive counterweight training within each geographical area, in the context of the trial, there'd be 120 patients going through the counterweight program. Of course, there would be no restriction on practices recruiting more patients, and I guess the process by which practices would be encouraged to do that would need some discussion, but that's the general plan. In terms of budget, we've estimated that the trial in total would cost around $1 million, and we'd aim to request half of that from the NHMRC. Counterweight would make happy to make a contribution in terms of no licensing fees and reduced training fees for the Counterweight program. And so that would leave the remainder to be requested from partners. And so we've estimated that the partner contribution would be split between a cash contribution of around $30,000 per year over the 3 years of the project, with an additional $20,000, the equivalent of $20,000 a year through in-kind support. So things like assistance in practice recruitment and retention, office space for research nurses. And in terms of the application, or the running of the trial, each geographical area or each partner would be assigned a research nurse who would be in charge of liaising with practices and patients, collecting the data. The practice nurses within the intervention practices would receive training initially, followed by the control practices at the end of the trial. And of course, the practices would receive the session payments according to the delivery of the program. So, from a partner perspective, if we just think about the 120 patients who would receive Counterweight in the context of the trial, the $30,000 a year equates to a cost of around $750 per trial patient receiving the Counterweight, plus the upskilling of 20 practice nurses within their jurisdiction. So hopefully that's not too much of a hard sell, but we just wanted to put it out there. This is what we're trying to do, and get some feedback if you have any, and if you are interested in being involved. Clearly we can take some questions now, but if you want to get in touch outside of the webinar, here's our website and our email addresses. I also wanted to just put up the acknowledgement slide at the end here to acknowledge the funding from the Australian Primary Healthcare Research Institute, and absolve them from any views or comments that we've put out today. So I'll stop there and note that we've got a few questions. Mark's going to speak to that. Okay, so thanks, Kirsten. So Kirsten Koppel, she's talking to Jodi. So do you want to?
Yep. No, it's more of I'll send something through.
Oh, okay. All right. So Kirsten's from New Zealand. Oh, she's all right. So second comment was from Liz Ray. Is there any scope with the new bundled care arrangements? So I might put that one to Mark if he's able to comment on that.
Well, there is. I guess there's certainly scope, even with the existing arrangements, although the funding is pretty tight under a care plan. But there is, I think, under the new arrangements, this would certainly be applicable. So just to expand on that, the Primary Health Advisory Group, this is a Commonwealth body, recommended that we introduce some patient enrolment and of patients with chronic conditions and a bundled payment. So that would include the ability to bundle services that might otherwise have been provided through Medicare. So it's based on a sort of cashing out, if you like, of what would have been the estimated Medicare services, including services that were provided under care plans. So theoretically, yes, we haven't got any details yet, and that's going to be starting with a trial in a number of the primary health networks. And I think the primary health networks have been asked to submit expressions of interest in undertaking those trials. I think with 500 practices to begin with, something like that. That's it. It's not hopefully going to stop at a trial, but the intention is it'll be rolled out. So this is the very sort of thing that this study would help to inform whether it was worthwhile funding this on the basis of savings that might otherwise be made, not just in Medicare, but in hospital services. The bundled arrangements, though, don't cash out hospital care. It only cashes out, as I understand them, the payments that might occur under Medicare, and possibly the pharmaceutical benefit scheme. We did show some data that we did in this stream that John and Jodi analysed some data from another study that we did called the PEP trial, where we looked at the Medicare and pharmaceutical benefits costs. And this was an intervention not as intensive as the one that we've been talking about in the counterweight program. This was essentially just supporting practices to provide more preventive care assessment and some preventive advice. And we found that had that doing assessments at least didn't increase costs, and there was a trend towards lower Medicare and pharmaceutical item costs, but that wasn't the level of significance that we needed to conclude that it was cost effective. So I think that it's very important that we do this kind of cost effectiveness studies to help inform how things like these bundle payments might be, how they might be cashed out.
All right, thanks, Mark. Oliver made a comment that we should think outside the current MBS item structure for funding counterweight. How about a PIP or QOF, which is quality outcomes? Anyway, it's for a pay for performance type payment for achieving an outcome. So looking at outcomes across a practice, I imagine. So I think there is. That would be an interesting way of going about it. Whether the data systems are in place to inform such a system in Australia, I guess would be one question. But certainly those QOF or pay performance type approaches have been used in the UK. There's varying opinions on their effectiveness or their impact, but yeah, we could certainly look at what's been going on in the UK, where they do have those type of payments. Yeah, so thanks for that, Oliver. Claire Madigan has said, great idea. She thinks that perhaps it would be easier to firstly look at the management plan as an option, as there are many people that would benefit from weight loss that don't yet have chronic disease, and we might be more likely to find an effect in this population compared to people who have diabetes and other health conditions. So yeah, I think that's a good point. I mean, you could make the case that the people with diabetes and other health conditions, it's more important for them to lose weight. So the downstream effects could be greater, but that's a good point. And Maria has asked if we can circulate the slides, and yes, we will. The webinar is being recorded and we put up on the HSR Association website. So we'll make sure that everyone who's attended gets information about that. There are no other questions, and it's actually just ticked over to 12:31 here in Adelaide. So that's our hour. So I think we'll draw it to a close. So thanks Oh, sorry. I'm going to just leave Mark. Mark's got the final slide. But I'll just say thanks to everyone for attending. We had a really good attendance. And thanks to Jodi and Mark for really good talks. I'll just hand over to Mark to talk about this last slide.
Yeah, so this is just a, for those in Sydney, really in New South Wales, there's another study that one of the members of Compare asked that we pass on to people, a diabetes prevention trial. So you can get information about this at the website that's on the screen. Yeah, if people are interested, if practices are in particular are interested, they could be put in touch with this group at Sydney Uni.
All right. Well, thanks very much, everyone, and we'll end the webinar there. Thank you.
Okay. Thanks. Bye-bye.
Right. If I can end the video.